stents. The indications are malignancy, recurrent benign esophageal stricture, and esophageal leaks. Malignancy is used only for palliation if the life expectancy is low. Recurrent benign esophageal strictures, this is mostly seen in anastomotic strictures. Esophageal leaks could be malignant or benign. The malignant leaks are usually due to esophageal respiratory fistula, and it's mostly due to a recurrent esophageal carcinoma, post-radiochemotherapy, or esophagectomy. The benign leaks could be due to Bierhoff syndrome, instrument perforation, anastomotic leaks as in a gastrectomy or an esophagectomy. The side effects of putting a stent include bleeding, aspiration pneumonia, perforation. There could be constant retrosternal pain, there could be a reflux, and the patient could have recurrent dysphagia if there is stent migration, food impaction, and tissue ingrowth. ESGE guidelines say the fully or partially covered SEMS is what is recommended for malignant dysphagia, because if you use an uncovered or a plastic stent, there is increased risk of migration and tumor ingrowth. Removing a PC stems can be difficult, like you need to remove it if the patient is having severe pain. But this can be done by a stent and stent method. So you put the same size FC SEMS inside the stent and you wait for 10 days. There is pressure necrosis around it, gets removed easily at the next sitting. The same method can be used if there is tumor ingrowth. So you remove it by grasping the distal end of the SEMS with a forceps. Balloon esophageal dilatation is usually not done in malignant stricture because there's a high risk of perforation. Treatment of a benign esophageal stricture. First, we try balloon dilatation. Second option would be, if it doesn't work, you do needle knife incisions in esophagogastric anastomotic strictures. You can even put 4-quadrant steroid injections for a peptide stricture, and the last option would be stent. And FC SEMS are used, but they're kept only for 6 to 8 weeks and definitely not more than 12 weeks. Refractory benign esophageal stricture. The definition is inability to dilate to 14 millimeters over 5 sessions at 2-week intervals. So there are 5 sessions at 2-week intervals, and you should not be able to dilate more than 14 millimeters. That is refractory benign esophageal stricture. And the causes are caustic injury, anastomotic strictures, radiation injury, and post-endoscopic therapy, which is becoming more common because of doing EMRs and ESDs. To prevent stent migration, you can anchor the stent with a through-the-scope clip or an over-the-scope clip, which is placed over the proximal mesh end into the esophageal wall. After you place a stent, you should give mashed liquids, not solids. The patient should gulp soda before and after to clean the mesh, the stent. Lupivon or domperidone can be used if the patient has increased risk of reflux, like for example, if the stent is traversing the GE junction and the patient has symptoms of vomiting, which could displace the stent. For a short period, of course. Choose the size of the stent by 2 centimeters above and 2 centimeters below the length of the stricture. The indication for proximal release stent would be if you want to fix the upper part, then you can use a proximal release stent. There are 4 types of stents: the fully covered SEMS, the partially covered SEMS, which are metal stents, and the SEPs, which is self-expandable metal plastic stents, and the biodegradable stents. ESG guidelines for esophageal stent: malignancy. FC SEMS or PC SEMS for palliation is preferred over laser photodynamic therapy. Brachytherapy as an alternative or an addition to the stent if longer life expectancy. SEMS can be used for sealing a malignant tracheoesophageal or bronchoesophageal fistula. SEMS is not used as a bridge therapy to surgery or chemoradiotherapy because there's a high risk of adverse events. What about benign strictures? Do not use a SEMS as a first line therapy. It's the last resort. You use a temporary FC SEMS for RBES. This is due to a low risk of embedment and ease of removability. And this should be done before 8 weeks, preferably. The stent in stent technique is used to remove the PC SEMS if embedded into the esophageal wall. Fully covered large diameter SEMS for refractory esophageal variceal bleed. This is another indication, and it's the initial therapy of a massive bleed as well. And this is your ESGE guidelines for an esophageal stent. And it can be considered for leak, fistula, and perforation even in benign disease as well.